Welcome to the Boston Cardiac YouTube channel. In the spirit of having a solar eclipse being seen in Massachusetts and all over the world tomorrow, I decided to make a case presentation, another diagnostic dilemma, and at the end you'll realize its relevance to the solar eclipse that we're going to see tomorrow. So without further ado, let's get started into the case presentation. So this is again an echo quiz, which will be a few echo clips will be shown along with the perspective of the clinical history. And after that, you will be asked to make a diagnosis, following which we'll have the display of the diagnosis as well as the clinical relevance of what this presentation and the clinical case is all about. So let's get started with the case presentation. So the case history is that this is an 81-year-old female with past medical history significant for chronic kidney disease and paroxysmal atrial fibrillation. She has severe mitral regurgitation, that what was reported to, which led to shortness of breath, and the T at the hospital and outside hospital demonstrated severe mitral regurgitation, whereas no specific mechanism was described. Her cardiac catheterization also was done at an outside hospital, which demonstrated diffuse non-obstructive left main disease, minimal luminal irregularities of the circumflex, as well as minimal luminal irregularities of the right coronary artery. So these are clips from her outpatient TE. As you can see, this is the mid-esophageal four-chamber view, which shows some thickened leaflets that you expect at this age group. There is mitral regurgitation, maybe mild, of a very short duration and not a very of not much impressive severity. We continue to look at the mitral regurgitation in the transcommissural view. Again, looks like it is coming from the P1 commissure or the anterolateral commissure, and a little bit from the posteromedial commissure. Again, nothing very dramatic about the severity of MR. This is the mid-esophageal long axis view, again showing some coaptation defect, but the MR is of about mild at tops moderate severity, and this is an outpatient TE. The patient was moving about a lot, so it's not entirely a very good quality TE. But let's get to the point in this examination. So 10 minutes into the procedure, and this is what it looks like. 10 minutes into the procedure, and as you can see that there is massive coaptation failure without any ST segment changes or some hemodynamic instability. There was some hypoxia, but you can see there is a massive coaptation failure. At the same time as that happened, that can be confirmed in multiple views. This is at 0 degrees, this is at the 45 degrees transcommissural view, demonstrating complete lack of coaptation between the posterior and the anterior leaflet, and obviously there is severe mitral regurgitation. And again, you can see a wide flow convergence in this location of vena contracta and jet expansion. This can also be seen in the live 3D image of the mid-esophageal long axis view, demonstrating any or lack of any coaptation between the anterior and the posterior leaflets. Take a look at it again. This is quite a dramatic mitral valve failure and retraction and somewhat annular dilation of both the leaflets. So again, there's severe mitral regurgitation. The patient was also demonstrating some ST segment changes, and therefore a nitroglycerin infusion was started, and immediately after nitroglycerin infusion, you can see that this leaflets start to coapt one more time, and the mitral regurgitation severity goes to what it was at baseline. Take a look at it one more time. This is when at the peak of that attack of hemodynamic instability, hypoxia, and severe mitral regurgitation, and you saw the one before that, that's baseline, there's good coaptation, some mitral regurgitation, but not as severe. So what is the diagnosis? So normal coaptation at baseline, then something happened leading to complete coaptation failure, leading to severe mitral regurgitation, and nitroglycerin infusion led to resumption of coaptation and reduction in severity of MR. So the diagnosis, as you can see the solar eclipse over here. This is a rare clinical condition called eclipsed mitral regurgitation, which is because of eclipsing of the blood supply that is going to the papillary muscles, somewhat of unknown etiology, but believed to be because of epicardial vasospasm in these patients. And as you can see, this is what it is, eclipsed mitral regurgitation. And it was first described in 2008. A few cases have been reported. This is a truly dramatic case. The true prevalence and cause are really unknown. It is eclipsed mitral valve was first thought to be related to epicardial coronary vasospasm, causing ischemic mitral regurgitation, but has been shown to occur in patients without vasospasm at the same time. So this is a case of eclipsed mitral regurgitation, and now you can imagine its relevance to tomorrow. That's when we are going to see the solar eclipse in Massachusetts and all of Northeast United States. In the same spirit, I would ask you to please save the date for this October 11 to 13, 2024, when we are going to resurrect our Boston Echo course that we used to do in Boston for about 14 years, then we discontinued for 5 or 6 years, and now bringing it back in October. This is going to be a fantastic masterclass in 3D imaging, with the unique part of this course being it's going to be entirely on case-based discussions with in-person and live streaming, also with a hands-on 3D workshop. So good to see you, and hope to see you soon at the Boston Echo course in October. Thank you very much.